Hello, everybody. Thank you very much. I had the microphone muted. So basically, thank you for joining us today. We will have also a pre-recorded session by Stephen Pletcher, and Dr. Pletcher is going to join us hopefully towards the end of the meeting, and he will be able to answer your questions and your comments. I found that this talk was specifically very informative, and I really wanted you guys to take a look. So again, we're hoping to see Dr. Pletcher towards the end. And if you have any questions, please use the chat line for your questions. And I think
and biologic talks and biologic treatments.
Sorry. Give me just 2 seconds and I will get things ready for you. All right, so here we go.
This is it's a very large topic, so I'm going to provide a relatively targeted talk for today in the areas that I think are most relevant and hopefully most helpful. So here's how we're going to break it down. I'll talk about the initial evaluation of chronic sinusitis with polyps. We'll talk a little bit about medical therapy in the beginning, then surgery and postoperative treatment. A lot of the interesting and newer medical therapy issues, I think, are most relevant in the postoperative setting, and so I'm going to save some of that for the postoperative treatment time. So these are the patients that we'll be talking about today, not the ones in general with little polyps here or there, but the patients who are majorly afflicted with sinonasal polyposis that impacts the majority of their sinuses and can be really challenging patients to manage over time, with a very high rate of recurrence of disease and inflammation. So let's talk briefly about the initial diagnosis for these patients. So not all polyps are the same. Clearly, this patient on the right side of our screen here has really massive inflammation. You can see the brighter material in the sinuses that is the hyperdense mucus, and we know that these patients are going to have a lot of inflammation and be severely impacted over time, whereas patients with a small polyp off of the middle turbinate oftentimes don't need any treatment at all. So there is a grading scale that we use for measuring severity. I think this is most helpful in research purposes, where we're looking to standardize polyp severity across patients to determine that we're using the appropriate, or that we're evaluating results appropriately by having a better understanding of who the true patients are that are involved in these studies. So this is the most common polyp grading system that you'll see. This is supposed to represent the right-sided nasal cavity, septum here, middle turbinate here, inferior turbinate. Grade 1 is still within the middle meatus area. Grade 2 extends out beyond the middle turbinate. Grade 3 down to the mid portion of the inferior turbinate, and grade 4 beyond that. Quality of life and quality of life nasal endoscopy are also very, very important. Nasal endoscopy obviously helps you do this grading component. And the CT score gives you a better sense of what's happening throughout the sinuses, not just with your view of the polyps themselves. There are many comorbid conditions that can occur in combination with nasal polyps. Two of the most common, I would say, are allergy and asthma. There is this entity that's been recently described by Dr. Delgadio and his team at Emory, which they describe as central compartment atopic disease or allergic disease. And these are really polyps that are oftentimes coming off of the middle turbinate themselves. Tends to be more isolated disease and tends to be much more closely associated with allergy. Whereas many of our patients who have more severe inflammatory disease have comorbid asthma. The prevalence varies, but in general, it's about 26% of patients. Patients with more severe polyps are more likely to have asthma. And interestingly, late onset asthma has a higher chance of having nasal polyposis. Also of interest, these patients oftentimes do not have significant atopic disease. Their allergy testing is oftentimes normal. Other comorbidities, there are subcategories of polyp patients: aspirin-exacerbated respiratory disease, allergic fungal sinusitis, cystic fibrosis, Sjögren's. These different phenotypes of polyp disease have some different treatment components. I'm not going to go too much in depth in these areas, but when you're first evaluating a patient, trying to determine if they do fall into one of these categories can be very helpful in their ongoing management. So as we talked about before, close attention to your CT and nasal endoscopy, consideration for allergy evaluation, definitely asking about asthma and any reaction to aspirin or non-steroidal anti-inflammatory medications. And then for these patients, increasingly, I'm doing a laboratory evaluation at their initial presentation that includes a CBC, primarily looking for their eosinophil count, looking at their total IgE level, and in some rare cases, considering an ESR or ANCA if we're suspecting some other type of vasculitis that might be contributing to their disease process. That's relatively rare in my practice. Here's a symptom score that's commonly used, the SNOT-22. This evaluates patients in general with chronic sinusitis and can be very helpful just in terms of tracking patients over time to determine how they are responding to various treatments that you're providing. Dr. Gray, my colleague for this talk, has also described that if you look specifically at the subset of cough, those patients are more likely to have asthma. If you look at the subset of questions that relate to sleep, sleep apnea can have a higher incidence in those patients, and patients who report otologic symptoms that are associated with the SNOT-22 test have a higher incidence of allergy. So it can also help you kind of subcategorize your patients to some degree. So moving on, let's talk a little bit about medical treatment for nasal polyps. This is a clinical practice guideline that was published in 2015. You can see a list of luminaries from our field who were involved in the development of these guidelines. This was an update from the 2007 guidelines that were published at that time. And here's sort of the net of their discussion. These are patients with possible sinusitis. You can see the duration up top, less than 4 weeks here. So those are acute sinusitis. Here's this subacute group that we rarely talk about and is generally not particularly clinically relevant. And it's over on the far side here that we see the category for patients with chronic sinusitis. I really just want to highlight the bottom. You go through this sort of, do they have polyps, do they not? Consider some irrigations and things. But the bottom line for their talk was they recommended medical or surgical management as appropriate. So really not a lot of specific guidance in terms of how to manage and treat these patients. Here's a list. I would say it's not comprehensive, but many of the common treatments that are used as medical treatments for patients with chronic sinusitis and polyps. The main categories: corticosteroids and antimicrobials, specifically antibiotics and antifungals, and then a whole list of other options, including aspirin desensitization, anti-leukotrienes, and then the various biologics that we'll talk about more later in the talk. I'm going to highlight these two areas, both the biologics and the specific macrolide subgroup of the antimicrobials, and just mention that I'm going to speak more about these really in the post-operative management of patients as opposed to in this medical treatment section. So we'll get back to these shortly. So this was a consensus statement that was published in 2016 in our IFAR journal that went through many of these treatments and looked at the evidence. So here first we're looking at the group. This is saline irrigation and then steroids, whether it's steroid sprays, steroid irrigations, or oral corticosteroids. And we're just going to focus briefly on what their policy recommendations are. And you can see that in general, these are recommended or considered as options. So, the typical recommendation is to use both saline irrigation and nasal steroid spray for your treatments as a starting point, and then consider other topical corticosteroids or oral corticosteroids as you're progressing with their management. However, I think we all know that if we just take these at the starting point with a patient like this and you recommend saline irrigations and nasal steroid spray, you're really not going to get anywhere significant with their management. But I do think it is always worth considering the option of oral corticosteroids in those patients who don't have significant contraindications. This was a patient of mine who was referred. He'd had surgery, I believe, in India in the past, and then had recurrence of his disease over time. He came to my clinic very symptomatic and with this CT scan showing very diffuse disease. We treated him with a course of oral prednisone starting at 40 milligrams and tapering down to 10 milligrams, 4 days at each level for a total of 16 days of treatment. And here is his CT scan afterwards. And you can see a pretty, not complete, but pretty remarkable improvement with oral corticosteroids alone. And when we look at his sagittal view, I think that if most people were putting up a pre and post-operative CT scan, they would be patting themselves on the back for what a good job, for what a good surgeon they are with these pre and post-op images. But this patient didn't have surgery at all, was just treated with oral corticosteroids. Now, this is certainly a more dramatic improvement than many of our patients who we see with this level of disease. But I put it up here just to reinforce the consideration for this treatment. And in general, this is something that I do for all of these patients as an initial treatment prior to surgery, as long as they don't have contraindications, to see how they respond. Sometimes patients who have this level of response, when we add in their irrigations and steroid irrigations afterwards, they'll maintain their improvement in symptoms, and we can follow them over time and spare them surgery. Moving on now, again, this is our same consensus statement. We're looking at antibiotics and antimicrobials. And again, let's look specifically at the policy recommendations. And you'll see, as in contradistinction to the first slide that I put up from this study, almost all of these are recommended against, and the best is an option here for macrolides. And again, we will talk a little bit more specifically about that. But the bottom line is that many of these, what we typically think of as classic treatment, or typically sinusitis is thought of as an infectious process, and so it would make sense that treating with antibiotics or antifungals would be helpful. But in general, there really is not a clear evidence in chronic sinusitis with polyps in the absence of an acute exacerbation that antibiotics provide particular benefit, with the one exception of macrolides that we'll talk about a little bit more. Here, looking at just a couple other, manuka honey and colloidal silver are rarely used, but anti-leukotrienes and aspirin desensitization, these are options or recommended for patients who specifically have AERD. Okay, let's move on to surgery. So I think it's always important to talk about the role of surgery in these patients. This is appropriate when medical therapy fails, and in many patients with the most dramatic disease, medical therapy will not provide significant improvement. And I really think of surgery as an adjunct to their medical treatment, not a cure for their disease. So certainly it can provide symptom improvement. It can reset the clock in terms of their level of polyp disease. You can sort of give them a clean starting point. Definitely, it improves access for topical delivery, topical medication delivery. I think that's one of the most important roles that we play in surgery, and one of the things that I emphasize to patients. I think one of the things I hate to see is patients have surgery, feel better, disappear from my clinic, don't do their topical treatments afterwards, and then come back with significant disease longer term. I think the other important role of surgery is it really does decrease the inflammatory burden in these patients. And so for some of them, that sort of combination of removing the inflammatory mucus, resetting the polyp clock and things, for some of them, that alone will provide prolonged symptomatic and endoscopic improvement. For really significant polyp disease, the best option is, if you're able to do a complete surgery the first time, which provides improved topical delivery for medications, as well as complete removal of inflammatory material from the sinuses. In terms of preoperative planning, I think it's always good to get a good sense of your disease status. Having a CT scan for image guidance can be helpful. Polyps can be quite deforming of normal anatomy, and I think the biggest take-home point for surgery in these patients is that You don't want to become disoriented during your surgery. You want to have a nice orderly progression of your procedure. Make sure you can do things in a safe way. You want to think about bleeding risk, and bleeding control is really an important component of surgery as well, so that you can maintain your visualization and orientation throughout the procedure. Preoperative antibiotics, I think, are really only indicated, in my opinion at this point, for patients who are having an acute exacerbation. Preoperative steroids can decrease the inflammatory burden. Talking specifically about systemic steroids here, can decrease the inflammatory burden, can also help control any comorbid asthma that these patients have, to make concerns related to their general anesthetic less significant, and sometimes simply makes the surgery easier by decreasing bleeding as well. I think the most important point on this slide is really to have a clear and realistic expectations for patients. In general, when patients come to see me, initially their thought is, yes, I want surgery so that I can be cured of this disease. And I think it's part of my responsibility to educate them that surgery is a part of their treatment process, but it's only a part, and they have a very high likelihood of needing ongoing medical therapy after their surgery. Other preoperative considerations, definitely optimizing control for surgery. So as we talked about, preoperative steroids for asthma control, and your realistic informed consent with the potential for polyp regrowth, and even the potential need for revision surgery in some patients. In terms of equipment, this is an older image guidance device, but I think typically I use image guidance for these patients, again, because of the anatomic deformity that can happen. I think it allows me to safely provide a more complete surgery in a number of patients, and so I think this is quite helpful. I'm also a heavy user of the microderbeator, which I think helps control bleeding, is very efficient at polyp removal, and can provide good visualization and control during your procedure. The one caveat for the microderbeator is it's very efficient at tissue removal. This is excellent for polyps, but can be disastrous if the microderbeator is utilized in areas at times of anatomic confusion. If it's placed in the orbit or in the intracranial cavity, the microderbeator is really what's been responsible for the most devastating complications of endoscopic sinus surgery. So it's always important to keep that in mind when you're using this device. In terms of prevention of bleeding, this shows use of a bent spinal needle to inject near the area of the sphenopalatine foramen and where the sphenopalatine artery comes out. I do not do this routinely, but I do have some colleagues who inject both there and along the inferior aspect of the middle turbinate, and believe it helps significantly with bleeding control. Personally, I am more of a pledget user. I use topical epinephrine pledgets, 1 to 1,000 pledgets, for my primary method of hemostasis during surgery. One warning with this, the 1 to 1,000 epinephrine can be fatal if injected. So it really needs to be utilized very carefully. You need to have an ironclad system if you're going to use this medication in your operating room to ensure that it's only used for pledgets. Typically, and the main concern is that oftentimes there are people who are using a combination of topical epinephrine pledgets as well as injecting lidocaine 1% with 1 to 100,000 epinephrine, again, 100 times less concentrated than the topical method. And if the concentrated material is injected, it can really be disastrous or even fatal for patients. So you need to have a very clear plan and method that is ironclad to prevent any injection of this material if you are using it in your operative field. So in general, for primary surgery, the goal is to remove all ethmoid partitions, to create very wide openings for the maxillary sphenoid and frontal sinuses for patients with significant disease in this area. And then you can also determine how to manage the middle turbinate in this during this surgery. So here's some videos here. We're just starting off with our uncinectomy and maxillary antrostomy. You can see removing some polyps from the middle meatus area. I think the first important point is just starting with a good polypectomy. And once you do that, you turn the initial portion of the polyp surgery into much more of a standard surgery. Here we're using a backbiter to remove the mid and inferior portions of the uncinate process here, as we're going to start looking for the natural ostium for maxillary sinus. And the other thing about polyp patients is oftentimes, as opposed to patients with less disease, you can be looking right at the natural ostium for the of the maxillary sinus, for instance, but not be able to see it because of the polyps and tissue edema around the area. This is true for other areas, including the sphenoid sinus as well. So you want to have a good anatomic sense of where these structures are, how if you follow the inferior aspect of the uncinate down and follow the sort of lateral aspect of the mucosa down, that will always lead you to your natural ostium, and then you have a good sense for where that is. Here we're just starting to enlarge the maxillary antrostomy in order to expose other areas. The maxillary sinus really provides nice landmarks, including the orbital floor, your lamina papyrica, and can give you a sense for the position of the sphenoid sinus as well. Moving on, here's our ethmoid bulla. Again, I typically use the microdebrider here, and I'll start medially between the bulla and the middle turbinate, pick out any polyps, and then I will try to enter the sinus space of the bulla, usually a little more inferiorly down here. And once you can see that airspace, you can then utilize that visualization to expose and work on the septations around the bulla to help start defining your medial orbital wall, and then posteriorly here your basal lamella as you're going to proceed moving along with your surgery. Oftentimes in polyp patients, the lumen of the bulla is full of either polyp or thick mucus, and so you need to debulk that first. Again, I think the microdebrider is a nice tool for that. Here we're looking to proceed through our basal lamella. So the basal lamella is the continuation of the middle turbinate as it turns laterally to attach to the orbit. We're going to enter the basal lamella inferiorly and medially here. Again, you can see using a microdebrider to do this, and we're going to create a window in the basal lamella. Again, we're looking specifically to enter and identify and expose the air spaces behind this region so that we can use that to identify our anatomic landmarks as we proceed with our dissection. After coming through the basal lamella, the next thing I think about is the sphenoidotomy portion of the procedure, is identifying the sphenoid sinus. So here's just a schematic of what things oftentimes look like at this time. Again, here we're in the right nasal cavity. This is the maxillary antrostomy over here. This patient's already had a more thorough ethmoidectomy than we've done in our patient. I think the key point of this slide is we can see the cut edge of the basal lamella right along here. And if you leave that cut edge of the basal lamella alone without manipulating it, you're not oftentimes going to be able to see your superior turbinate well. But if you take an instrument here, it shows a freer elevator, and you use that to push your basal lamella over against your septum, you can expose the superior turbinate and this cleft, the superior meatus between the superior turbinate and the septum here, which is going to be the site of our sphenoid ostium. So this just shows the actual visualization in our patient. Here's the open maxillary antrostomy. This is the basal lamella, the cut edge of the basal lamella right here. Here's using a suction to push that basal lamella up against the septum, and now we're seeing the sphenoid sinus. So let's see what that looks like in the video here. Again, maxillary antrostomy, orbits over here, basal lamella here. Here's the window that we've created into our basal lamella. We're going to use our microdebrider to push this basal lamella against the septum and expose the superior turbinate beyond here. So as we do that, here we're sliding in, pushing the basal lamella over. The superior turbinate is right here, and oftentimes that superior turbinate forms the medial wall of a posterior ethmoid cell. So you can see as we start taking the superior turbinate down, we're actually going to enter a significant sized posterior ethmoid cell right here. When we see that aeration, that provides a lot of the visualization and our anatomic orientation to proceed with the surgery. Here we're removing the inferior portion of the superior turbinate. The sphenoid ostium always sits between the superior turbinate and the septum. Entering through the ostium is the safest and most physiologic approach to this area. So that's the approach that I always prefer for these cases. Here we're enlarging our sphenoid ostium after it's been identified. And once we have this enlarged sphenoidotomy, it also, again, provides some orientation for where we are. We've got a lot of residual ethmoid septations here now, but we're starting to clearly define our medial orbital wall to the side of all of these septations. Also, our skull base is being defined both by the roof of our sphenoid and the continuation of that as it proceeds along the roof of the posterior ethmoids. The skull base roof, based on the positioning of patients that during sinus surgery, is always more lower down, more posteriorly, and fades away from us as we come anteriorly. So here we're just cleaning off polyps and the polypoid disease along these residual ethmoid septations coming from posterior to anteriorly, both along the skull base and the medial orbital wall to create a wide open ethmoid cavity. Our goal is to avoid mucosal stripping of the tissue that we're leaving behind. So we want to leave a nice mucosal covered medial orbital wall and skull base. Also, looking at the position of the anterior ethmoid artery on your preoperative CT scan is important. Sometimes this is hanging inferiorly and can be at risk as you're proceeding more anteriorly with your dissection along the skull base. A few instruments that are helpful as we transition from the ethmoidectomy to our frontal recess dissection, both having angled endoscopes as well as angled instrumentation. I do prefer through-cutting instrumentation in this area in general. This is an angled or cobra kerrison, which we use frequently. This is a Hoseman punch, which is nice because it works in any direction as opposed to just anteriorly like the kerrison. The kerrison is easier to clean, a little more efficient, but I think they both have their place. This is an angled image guidance probe and an angled image guidance suction, as well as some grasping and through-cutting instruments that are angled to access your frontal recess. Also use of an angled microderiviter blade. I oftentimes use the pediatric blade, the 2.9 millimeter blade in this area, just because it's thinner and a little bit easier to manipulate. Does jam more frequently, but oftentimes allows you to perform a nice dissection in the area. This was a paper that we wrote a number of years ago that helped just describe some additional exposure to this area. Now we're in the left nasal cavity. Here's the nasal septum. Here's the middle turbinate. This is what we refer to as the axilla of the middle turbinate. And oftentimes after you take down the uncinate, there's this region right here, which is the face of an Augernazzi cell. That's simply the extension of your axilla superiorly. So using I usually use a gently curved kerrison. You can do it with a straight kerrison as well. Just kind of slide right in this area and take down this face of the Augernazzi cell. And that just provides a much wider view of the, and easier visualization of the cells and septations in the frontal recess region. Now, when you do this, you do destabilize the middle turbinate to some degree. So considering how to stabilize, or if you're planning to resect the turbinate in the future, but having a plan based on that. So here's a frontal sinus dissection. This is now on the right side. After we've exposed that area, this is using a kerrison, a curette to remove some of the, one of the underlying septations there. For patients with our polyp disease, oftentimes they'll have this thick mucus in this area. If you leave that behind, they're going to recur very quickly. So making sure to get all of that out. Oftentimes I will slide a curved suction with a large flush in there and do multiple irrigations to make sure that that area is cleaned well. Revision surgery, this is oftentimes the scenario in which I see patients who've had surgery in the past and then are referred for recurrent disease. Consider wider antrostomy. Sometimes the polyps have done a nice widening of that area to start. So mega antrostomy or medial maxillectomy is frequently not needed, but occasionally could be helpful. Wide sphenoidotomy is definitely important. Looking for residual ethmoid partitions, and then deciding how to manage both the frontal sinuses, the frontal recess area, and the middle turbinates. For patients with extensive frontal disease, sometimes a draft 3 or drill out procedure can be helpful. And for patients with significant polyps coming off of the middle turbinates in this setting, oftentimes middle turbinate resection can be beneficial for them as well. So again, think about the middle turbinate. If it's grossly involved with polyp disease, even at the primary case, I'll oftentimes remove it. In general, I will leave it in place if it's not at a primary case. And when it's grossly involved with polyps or markedly edematous, it can certainly inhibit your ability to provide topical medication postoperatively. This is just a postoperative CT scan of a patient who's had a medial maxillectomy, endoscopic medial maxillectomy. You can see the inferior turbinates and the medial wall of the maxillary sinus have been removed to create this very sort of wide open maxillary sinus area. Certainly in some patients, if you were to do this routinely in patients, you would be concerned about issues related to nasal dryness, empty nose syndrome. In general, our polyp patients have the opposite problem. They're too wet instead of too dry. And so they rarely develop, for patients with true extensive polyp disease who you're really considering this program or this procedure, it would be very unusual for them to have the empty nose consequences. Here's another patient. You can see the significant frontal sinus disease here. And as we're, and one approach is the draft 3. You can see that we've removed the upper portion of the nasal septum as well as the floor of the frontal sinuses bilaterally to once again create that really wide opening into the frontal sinuses. And we'll see another patient with this in just a minute, but as we're looking superiorly, we can see that wide opening into the frontal sinuses bilaterally, right side over here, and this is sort of the continuation of the nasal septum posteriorly that's been partly resected. Postoperative management, sorry, it looks like I did annotate something here, but we'll ignore that for now. So moving on to postoperative management. Nasal packing is one of the things to think about, and really this starts at the end of surgery. For topical treatment in this setting, there are a few different considerations for nasal packing. So one is hemostasis, another is to use it as a spacer to keep the middle turbinate in the location that you want, and then drug delivery is really the reason that I most frequently use nasal packing as a mechanism to start my topical steroid treatment at the completion of surgery. There are some steroid-eluting stents that are designed for this. I most frequently use a off-label carboxymethylcellulose foam, also known as Stamberger foam, which can be hydrated with triamcinolone instead of sterile water. This is just some data looking at the steroid-eluting stents. This is from several years ago, but it shows a significant decrease in postoperative interventions and requirement for surgical interventions and requirement for oral steroid treatments and in polyposis with stent use. This was a study that was published in 2012. It was industry funded, but did show some significant results. The reason that I don't primarily use this is for patients like this. This was a patient of mine, again, significant polyp disease and diffuse inflammatory disease. We did surgery and used the Propel implant stents at the completion of the surgery. I started him on irrigations starting the day after surgery, and continued to see him. This is about 4 weeks after surgery, and you can see how the stent has started to dissolve, and it's kind of crusted, and looks like there's microbial overgrowth involving the stent, and that alone is providing some increased inflammation in the areas. It's not, at this point, as it started to degrade, it's also not particularly easy to remove in clinic. It takes a little bit of time to remove all the different particles. If you talk to the company, they'll tell you that removing the stent at 2 weeks is oftentimes what they recommend to prevent crusting. But my sense is also that these stents are underdosed in terms of steroids for treatment of really severe polyp disease. So this is typically not my preferred approach. The Sinuva treatment, this is designed for not at the time of surgery, but postoperatively, if patients are starting to develop recurrent polyp disease, to be deployed in clinic. It's similar material with a higher steroid dose than the Propel stent. This is about double the dose of the Propel stent. This was a randomized control study looking at use of Sinuva in patients in clinic. It was published in April 2018 in IFAR. It had a quite large study, 300 patients, randomized 2-to-1 Sinuva versus a sham procedure. All patients were treated with a nasal steroid spray, mometasone, daily, and then they looked at symptom scores and polyp scores as their primary endpoints. So here's the nasal obstruction or congestion score. This was a 0 to 3 scale, and they look at in the treatment group, it went down by 0.8. In the control group, it went down by 0.56. So there was a difference, 0.23 difference that was statistically significant, primarily because they had a very large patient cohort. But you can see a relatively modest improvement in nasal congestion score. If you look at bilateral polyp grade, they did use a system where they had an independent blinded panel. They also had surgeons score on their own. So this is the data from the independent blinded panel. And again, you can see here that the treatment group, they went down. This is now a 0 to 8 score. The treatment group went down by ½ a point. So relatively modest, whereas the nasal steroid spray alone control group went down by 0.15. Again, a statistically significant difference, but relatively small difference. Here's some, and again, here's our polyp grading score, 0, 1, 2, 3, 4. It gets to 8 because they're looking at both sides. So if you think about the difference, this is a 0.35 divided by 2 because it's only on one side, and then really you end up with a pretty minimal change in polyp. Here are some figures from their study. This looks at the nasal obstruction score, and you can see the two curves. Here's the sinus implant plus the nasal steroid spray. And there's a difference, but relatively modest. Now, I think what's important to point out about this study, let's look at their figure for the polyp grade. So here we see the sham plus mometasone, and here's with the actual implant. Now, this looks impressive. We've got coming up to almost a 2 points change in polyp degree from baseline. So what's going on? Why do we see this figure here versus the actual table of relatively modest impact? Well, you have to read closely because this is the figure that they put in is the bilateral polyp grade by the clinical investigator. So this is not blinded. This is by the clinical investigators looking at it. Whereas what's in the table is the actual sort of classic study design where you'd have an independent blinded panel. And so there's a significant difference that they saw between the clinical investigator scoring and the blinded panel scoring. Now, if I'd been the reviewer for this paper, I would not have allowed this table in because it really can be deceiving when you're trying to sort out the true impact of this. And the whole reason you have an independent blinded panel is to remove any potential bias from the investigators as they're unblinded and evaluating these patients postoperatively. They did comment on this in the study. They said the reasons for these differences are unclear, but may reflect limitations in video endoscopy review without clinical information to fully appraise the magnitude of change. Again, I don't find this a satisfactory explanation for using that table when you set up the study specifically to have a blinded panel review. So moving on, we'll talk a little bit about maintenance therapy, BDS-90 irrigations. There are several studies. These are some older ones. There are some newer ones out as well that look at this and do demonstrate some improvement. I generally find this, generally use this only in the postoperative treatment setting where the irrigations are actually able to access the sinuses. The 0.5 milligrams of budesonide per 2 cc's is typically the approach that I use. This is, again, an off-label use of this medication, but I think can be a helpful maintenance treatment for patients with chronic sinusitis and polyps after their surgery. I'll typically follow them over time and start them on this twice daily initially after their surgery, and then follow them over time and taper their treatments off with the goal of just getting them onto saline irrigations eventually. So how about the question, can we salvage surgical patients? So this is one of the challenges that we're certainly aware of is recurrence of inflammation in patients. So let's go through a case to look at that. This was a patient of mine. Again, you can see this sort of significant diffuse inflammatory disease. If you look closely at the maxillary sinus, you can see a little bit of hyperdensity within here. This is generally that kind of thick, inspissated eosinophilic appearing mucus that we'll see in patients. So here's just a couple of images from her surgery. That was her left maxillary sinus. You can see that thick yellowish material. Here we are. This is before any debridement following her surgery. You can see we left her middle turbinate in place. And here we're just looking in. This is up towards her frontal sinus. Here's some crusting that we'll clean out as part of our debridement. Ethmoid cavity here. And we can see back towards her, into her sphenoid sinus as well down here. Then we'll see a relatively wide maxillary antrostomy in this area over here. So at this point, she was feeling markedly better. She needed a debridement. We cleaned her out, continued to do well and feel well, and we started her on budesonide irrigations. She came back to our clinic 3 months later, said she caught a cold and lost her sense of smell, and now had increased nasal congestion. This is always a worrisome findings in these patients. So this was her nasal endoscopy 3 months later, and as we look in, we see just the sort of recurrence of this thick yellowish greenish mucin here filling the ethmoid cavity, and we're just working to kind of suction it out and try and clean her out in clinic as best we can. See, interestingly, the maxillary sinus is relatively spared, but there's really this marked polyp and inflammatory recurrence throughout the ethmoid cavity. So it raises the question, what do we do in these cases? Was this a technical surgical error? Does this patient need revision surgery? That would be pretty unfortunate 3 months after her initial procedure to have to go right back in. Medical treatments, culture-directed antibiotics. Oftentimes that material that you suction out will culture staph. Oral prednisone, topical steroid treatments. Should we start her on a biologic? We'll talk a little bit more about that. I think these are all reasonable things to consider. What we chose for her was use of a steroid foam treatment. I think this is not an FDA-approved procedure, and this is simply carboxymethylcellulose hydrated with 8 cc's of Kenalog 40. And so we'll show you what that looks like here. So this is simply at the end of that last debridement that we performed in clinic where she had so much inflammatory disease in her ethmoid cavity. We're sliding this, we're treating her with the steroid foam in clinic. After one treatment, we see her back in a couple of weeks. We can see that while there's still some significant inflammation, things have improved. We gave her one more treatment, and now we're seeing her back a month later. Now we can again see our sphenoid sinus. Our ethmoid cavity has opened up again. We can see nicely up into our frontal sinus. So there are salvage options for some of these patients. Again, you can see our normal maxillary sinus. And here she is again 3 months later. This is just with budesonide irrigations now. And we see that nice wide open ethmoid cavity and what we're hoping for in that scenario. So this is something that I do use intermittently in patients who have early recurrence of inflammatory disease. Here's another patient. This is a 59-year-old gentleman. He had Asperger's, aspirated respiratory disease, and polyps. I met him after he had 3 prior endoscopic surgeries. We did a revision surgery, including a modified Lothar procedure, and he came back 6 months later with frontal headache and congestion. So let's see what he looks like here. Here you can see this is the nasal septum and the cut edge of the nasal septum for his Lothar. He's got a little bit of polypoid material here along the remnant of his middle turbinate. And then as we look up to the area where we think we should be looking into the frontal sinuses, we can see it's just completely full of polyps in that region. So we first irrigated that area by sliding a suction, curved suction in there with some saline. There's a little bit of mucus that came out. And now we've got, on a curved suction tip, we've got some of the same Stamberger foam material that we're infusing into the frontal sinus. You can see as we do that, it starts to kind of squeeze out a little bit between the polyps here as well. This is, again, the cut edge of our septum, and our suction tip is placing this up into the frontal sinus. We see him back in 2 weeks, 2 weeks later in clinic. And now as we look up, you can see that the topical steroid has had a significant impact on the polyps in that area and has really reestablished the frontal sinus cavities here. We can see nicely into the frontal sinuses. His symptoms are improved. And this is him a year later where we're looking in. And now as we look up, he's maintained that nice aeration of his frontal sinuses. So I think this can be a nice adjunct and a nice trick to kind of help patients work through some of their clinical exacerbations and maintain the improvement that they gained with prior surgery. Okay, let's talk about biologics now. So we're going to talk about 3 things, or a few things. We'll talk about the anti-IgE treatment, omalizumab or Xolair. There are multiple anti-IL-5 biologic treatments, mepolizumab, restylizumab, and benralizumab. And then the anti-IL-4 and IL-13 treatment, which is dupilumab. This is targets an anti-IL-4 receptor, which is a shared receptor for IL-13, so it has an impact on both of these areas. So just a quick warning, next slide is an immunology slide. These can be confusing and challenging, so fair notice for everyone. But I think I'm just going to do a couple of takeaway points here as opposed to getting into the details of all of this information. Here's the bottom line is that this is where we end up with chronic sinusitis and polyps, oftentimes driven by eosinophils. This is all information that we know. I think what's kind of come out over the years more recently is that there are 2 kind of general pathways that are thought of to drive this eosinophilic inflammation. One is through epithelial injury, and a second is through our sort of more traditional antigen allergy type approach. Both of these can end up in this sort of common pathway of driving eosinophil production and inflammation. There are a variety of cytokines involved in multiple aspects of this, and many of those are areas that are targeted with our current biologics. So the anti-IL-5 treatments, IL-5 is a very important potentiator for eosinophils, allows them to prevent going into apoptosis and continue their impact. IL-4 and IL-13 actually, you can see, can drive this process from both sides. And then the IgE treatment is really isolated to this antigen IgE component of the process. So we'll leave our immunology at that and talk a little bit about some of the results. This is a meta-analysis. It's a little dated now from 2017, looking at some of these treatments in polyps. This is specifically for omalizumab, the anti-IgE treatment. And again, uses our same polyp grading system. And you can see that when they looked at 3 studies, all very small, when they combined those, they were approaching but not quite achieving statistical significance in terms of improvement with the biologic therapy. One of these included patients without asthma, so when they took that group out, then they did have statistically significant improvement. There is a much larger trial that has been now completed. This is a phase 3 trial run by Genentech, which is the maker of omalizumab Ryzolair. And they were doing study. They did a randomized placebo-controlled study with the goal of achieving FDA approval for this medication as a treatment for chronic sinusitis with nasal polyposis. So this was they looked at both Q2 week and Q4 week dosing. They looked at the inclusion criteria were a nasal polyp score of 5 or greater. That's the combined score for both sides. And you also had to have a score of at least 2 on each side. This was in their press release. This was from June of 2019. They reported statistically significant and clinically relevant improvements in polyp and nasal congestion scores. These studies are not out yet not published yet that I'm aware of for review, but they have submitted this information to the FDA. This was a press release from December of 2019, so very recently. So this was submitted. The FDA accepted the submission. They have not approved the medication at this point. So if approved, Xolair would become the first antibody to help reduce the size of nasal polyps through targeting and blocking of immunoglobulin E. Again, this was the press release that's put out by the company. There is another antibody treatment that uses a different mechanism that is currently approved for treatment of polyps, and that's dupilumab that we'll talk about shortly. In general, our clinical experience with this medication at this point has been limited to patients with asthma who are receiving the omalizumab treatment as a part of their asthma treatment, but we can also see how it impacts their chronic sinus disease and polyps. So this is a patient of mine who had a history of chronic sinus disease and polyps and had been on omalizumab for some time for his asthma. Here was his endoscopy at the time. You can see he's got a little bit of scarring, but really not much inflammation here overall. Nice wide open maxillary sinus down here, and we'll be able to see up into the frontal sinus here as well. He, for insurance reasons, had to stop his omalizumab treatment. So here he is 1 month after stopping treatment. And as we look in here now, we can see the initiation of some inflammation both along the posterior maxillary wall. You can see that sort of bumpy inflammatory tissue. And we can also see this polyps up here in the frontal recess that are now obstructing our frontal sinus. Fortunately, he was able to get back on his medication. And now here he is 2 months after restarting the omalizumab. It's a little narrow here, so we're just squeezing in and getting our view. But again, you can see resolution of much of that inflammatory change, the polyps that were in the frontal recess. You now see up into the frontal sinus, and also the inflammatory change that had been along the posterior wall of the maxillary sinus has now improved. So clearly, it does seem like there's a category of patients who improve with this treatment. Mepolizumab and restylizumab, as well as these are anti-IL-5 antibodies. For asthma treatment, an elevated eosinophil count predicts improvement in asthma. So again, our use of these medications to date has really been limited for patients from a sinusitis standpoint who have concomitant asthma as well as eosinophilia. In the same meta-analysis, again, we can see very small study or very small patient numbers in the studies, but they do notice a statistically significant improvement in the polyp score. So here's a patient of mine again who had significant chronic sinus disease. You can see she'd had surgery in the past. You can see this kind of yellowish, the marked edema of the middle turbinate. We can also see some of a lot of this thick mucin and debris that's reaccumulated in her sinuses here. So we're going to suction her out. She was started on mepolizumab. She had significant asthma as well, and we see really a marked improvement or resolution of her disease here. We can see the surgery that we did to widely expose her ethmoid cavity, maxillary sinus, sphenoid sinus, and we saw her frontal sinus up there before. While this has been, I have had a few patients with this type of response. I've also had many patients in whom I've been relatively disappointed in a lack of response for mepolizumab treatment or other anti-IL-5 treatments. So I think it's still a little bit hit or miss, and we're not great at predicting which patients will really have that significant improvement from this biologic treatment. Dupilumab. So this was the anti-IL-4, anti-IL-13 treatment. This was approved by the FDA in June of 2019 as a treatment for chronic rhinosinusitis with nasal polyps. Let's talk about a little bit of the data that that led to this approval. So this was a study that looked at adult patients prior treatment with systemic corticosteroids, or that had contraindications to or intolerance to systemic corticosteroids in the past 2 years, or prior surgery for nasal polyps. They also had to have a bilateral polyp score of at least 5. It had to be at least 2 for each nostril. So the omalizumab study was actually performed later than this, so they was designed, but similar design overall. And they also had to have symptoms of chronic sinusitis. The recent sinus surgery, I would say, was the most important exclusion criteria. There is some evidence that treatment with dupilumab can create a temporary increase in eosinophil count. So patients with really severe asthma, they excluded. This is a relatively small proportion of our patients, fortunately. So here are the demographics for this study, and we'll look at a few key points. So patients who've had at least 1 prior surgery, you can see a significant majority of patients, almost 3/4 in the placebo group, and just a little bit less than that, almost 70% in the dupilumab group. Comorbid asthma, 60% in the placebo group, and about the same in the dupilumab group. So this, unlike sort of our clinical practice with biologics prior to this treatment, asthma is not a requirement for treatment with this biologic medication. Total Lund Mackay score, the maximum you can get is 24. You can see the really significant levels of disease with the mean Lund Mackay score approaching 20 in both groups. And baseline eosinophil count is the last one I'll highlight. You can see a marked eosinophilia present in both of these patient populations. Here are their primary outcome measures from the study. This is at 24 weeks, so a little approaching 6 months. And here's the change for nasal polyp score at that point. And again, this is a 0 to 8 score because we're looking at both sides. So the total polyp change score averaged about 2 with 6 months of dupilumab treatment. So that's a polyp score increase on average of 1 on each side of the nose. Now, interestingly, they did stop treatment and follow these patients for another 6 months. And what you see is there's a significant improvement that's achieved at about 4 weeks and perhaps a little bit of additional improvement up to 6 weeks. But once you stop that medication, they quickly start reverting back to their normal course. Similar results for nasal congestion. You see a significant improvement. This is on a 3-point scale, and you have almost a 1-point improvement in nasal congestion here. And what we see when we look at nasal congestion over time, the same story, that it improves. But once the medication is stopped, there is a relatively speedy recurrence of disease and recurrence of symptoms. They also included a 52-week study with a dose reduction. So this is dupilumab is given as injections twice weekly. In this study, they had 3 groups. They had their placebo group, their twice weekly group, and they had a group that went twice weekly through 6 months or 24 weeks, and then went out to every 4 weeks after that. So sort of a maintenance dose of every 4 weeks after 6 months of treatment with 2 weeks. So the placebo group, you can see, stays basically the same here. This is their nasal polyp score again, whereas both of these treatment groups improve out to 24 weeks as with their prior data reporting. But the patients who continued on the 2-week dosing had some continued improvement going out to 52 weeks. It was really very similar for the dosing out to of every 4 weeks, starting at the sort of dose decrease patient population after 6 months of treatment. This dose decrease is not approved by the FDA, so this is not an approved treatment, whereas the every 2-week treatment is the approved dosing even after 24 weeks. Here's just a quick clinical slide or clinical video of a patient of mine. Again, this is someone who's had a draft 3 procedure in the past. You can see the extensive polyp disease and just sort of generalized inflammation in the ethmoid cavity here and extending up into the frontal sinuses. And here he is after dupilumab. This is just 6 weeks of treatment, so we'd expect continued improvement at this point, but we can now see nicely up into his frontal sinuses. So dupilumab is FDA approved to be prescribed by or in consultation with a specialist. This is not something to be given by a primary care physician, and that includes us. We do prescribe dupilumab out of our clinic for appropriate patients. It is only FDA approved for patients 18 years or older because that was our study population that led to the approval. They have to have chronic sinusitis with polyps confirmed by endoscopy or CT scan. They have to have prior therapy. Their sinus disease has to be inadequately controlled by medical therapy with intranasal corticosteroids and either one of the following. So nasal steroid spray plus systemic corticosteroids, or contraindication to systemic corticosteroids, or they have to have had prior surgery. Most of the patients who I consider for this treatment have both had prior surgery and have had at least short courses of systemic corticosteroids without prolonged improvements or the ability to maintain improvement with topical treatment after that. So what are the concerns for these treatments? Well, cost and access are major issues. These medications run in the range of $40,000 per year in terms of cost. The duration of treatment, based on the kind of recurrence of disease following stopping of these biologic treatments, there's no known treatment end date, and so that combined with the cost becomes very concerning. Reversal of disease, again, after stopping the medication with return of inflammation. And I think the other sort of key issue is how do we choose the correct patient and the correct biologic? And I think hopefully this is an area that we will improve on as we move along, but we definitely have significant room for improvements. This was just a consensus group, what they call the Euphoria. Sounds like they were very excited about dupilumab treatment. So they're talking about indications for biologics in treatment of chronic sinusitis. So number one, you have to have bilateral polyps. And they divided the group into 2 categories. Again, this is just expert opinion, not really evidence-based, but history of surgery or no history of surgery. If you've had surgery, then you should have at least 3 things: evidence of type 2 inflammation, need for systemic corticosteroids, significant improved quality of life, loss of smell, and comorbid asthma. If you haven't had surgery, you should have at least 4 of these before considering treatment with a biologic. They also describe defining what's an appropriate response to this treatment or how to follow these patients over time. So they recommended evaluating with 5 criteria: size of nasal polyps, need for systemic corticosteroids, and then improvement in these symptoms, as well as reduction of impact of comorbidities, most significantly asthma. They suggested evaluating after 16 weeks. If you've had improvement, if you've had no improvement at all, you can discontinue. If you've had some improvement, continue treatment for a year, and then you can categorize your response based on the number of criteria which demonstrated improvement: excellent, moderate, poor, or no response. Patients who are not candidates for biologic treatment, so chronic sinusitis without nasal polyposis and without signs of type 2 inflammation, cystic fibrosis, unilateral nasal polyps, mucoceles, immunodeficiency, and patients' factors such as noncompliance. So you saw the listing of type 2 inflammation. I think it raises a good question. What is that, and how do we define that? So it brings up a couple of important terms, which is the concept of a phenotype and the concepts of an endotype. So a phenotype is something that is clinically visible. So the typical phenotype that we use is polyps versus non-polyps, whereas an endotype is defined by a distinct functional or pathobiological mechanism. So we'll talk a little bit more about that. This is a classic paper from 2008 from Rob Kern and his group in Northwestern, and it uses the phenotype without polyps or with polyps, and then lists the endotype, which is typically or most typically associated with that. Now, back in 2008 and around that time, our sense was that most of these cytokines were coming from T cells, and so we call it the Th2, the T helper cell type 2 cytokine profile. We now know that many of these cytokines come from other cells, including epithelial cells, so that's the change from the Th2 to the type 2 response as the terminology we use currently. Now, while I think this is a really nice paper and was really sort of visionary at the time, it does, it has imperfections, and specifically, if we're making decisions for extremely expensive medications with prolonged treatment times, the degree to which these two are related, or the potential for false associations in this setting still exists. So while this is true for the majority of chronic sinusitis patients with polyps, that they tend to have this profile, and patients without polyps tend to have this profile, it's not true for everyone. And so I think we need to sort of get to a point where we can move beyond this, just using the phenotype, just using polyps to define our appropriate treatment. I'm going to show you a couple of cases that has sort of informed why I think this is an important distinction. So here's a patient. This is a 53-year-old gentleman who was referred for chronic sinusitis. He had a new onset and has had subsequently persistent symptoms for a little over a year. The typical symptoms that we would suspect. He had not previously been diagnosed with asthma, but he did note some intermittent wheezing and cough, and he was on an inhaled steroid treatment. He went through allergy testing, which was negative. He did have some temporary relief from oral steroids. Here's his endoscopy in clinic. And as we look in, here's the nasal septum. We're going to touch his middle turbinate just to defog our camera a little bit. You can see edema in the middle meatus area, and perhaps a little bit of bulging here, but really no nasal polyps overall. We can see all the way back into the nasopharynx. Here's the inferior turbinate. So here's our patient's chronic sinusitis, no polyps, no nasal polyps, but he's got lower airway symptoms. He's got symptoms of asthma. He has late onset disease, which is typical for this type 2 inflammation. He had a marked response to oral steroids, again, typical for this level of inflammation. Negative allergy testing is oftentimes seen in these type 2 patients. And he also has some pretty remarkable CT findings. So here's his CT scan, and we can see when we look in with our endoscopy, we're really missing what's happening with him. We're seeing some swelling around the middle turbinate and middle meatus area, but we're not seeing any polyps extending into the nasal cavity on either side. We can see all the way back to the nasopharynx, and the inferior turbinates look relatively normal. But what we're missing is this really marked inflammation throughout his paranasal sinuses. You can see this hyperdense material in the maxillary sinus, which goes along with that thick and spissated mucus that we typically see. So here's our patient in the operating room. As we're looking in on his right side here, we've already opened his maxillary sinus, and I'm passing a curved suction tip that's attached to an irrigation, and we're going to flush that sinus. And as we irrigate, you can see this really extensive, copious amount of thick inflammatory mucus that we just sort of push all the way out of the nose. And then this has been referred to as the two-handed technique. Sorry for the shaky video here, but you can see how thick and stretchy and really impressive this mucin is that we're pulling out from his maxillary sinus. On his left side, we did a single fast blast, and this whole area came out of his this whole material mucus. This is my one slow-mo video just to truly capture the sort of characteristics and nature of this mucus and the amount of it that can be in those sinuses. So how can we endotype this patient? Well, we can think about operative pathology. So what do we see when we see this patient in the operating room? We no longer really think of him as a standard chronic sinusitis without polyp patient, because he's got polyps in the sinuses that simply weren't coming out into the nasal cavity. And he also has the thick eosinophilic mucin that's typical for these type 2 patients, type 2 inflammation patients, that's oftentimes associated with pathology. Laboratory evaluation can also be helpful in these patients. One of the other issues that we talked about is, in general, when we send pathologic material after surgery to our pathologist, we get back chronic inflammation. But there's a lot more to that story, and with appropriate communication with our pathologists we are in the process of implementing a structured pathology report that reports on things including eosinophil counts. So here's the pathology from that patient who I just showed you. You can see this is the polyp with the epithelium here. This is some of the mucin that we were flushing out. You can see a few red blood cells, but in the polyp and in the tissue itself, you see these multiple eosinophils throughout the polyp with the marked stromal edema that's characteristic for these patients. When you look closely at the mucin itself, you see not only these kind of aggregates of eosinophils, but also charcoal-laden crystals. Now, this patient was stained and there is no fungus present. So these findings, although they're oftentimes associated with allergic fungal sinusitis, can also be seen with severe type 2 inflammation as seen in our patient. So this is a patient with a phenotype of no polyps, but their endotype is of type 2 inflammation. And I think this is a more important assessment in terms of determining whether they're candidates for patients such as biologic material. So this is a patient with eosinophil-rich mucin and inflamed sinus mucosa. He did grow Staph aureus. And what I didn't show you is that his blood work at the time of presentation, he had a markedly increased eosinophil count, as well as a significant increase in his total IgE. So all of these go along with the, if we think back to Dr. Kern's paper, these are all findings that are typically associated with chronic sinusitis with polyps or type 2 inflammation. So this patient has a higher likelihood of recurrent inflammation. He's going to be steroid responsive, and he's also going to be a reasonable candidate for biologic treatment. Here's a second patient. This is a 48-year-old woman who had had prior surgery. She developed bilateral nasal congestion, postnasal drainage, et cetera, about a year ago. She was treated with oral steroids, but really had, and as well as topical steroids, but really had minimal treatment or minimal improvement with this, as well as with antibiotic treatment. She had persistent inflammation and early polyp recurrence following surgery, and we tried to treat her again after surgery with topical and oral steroid treatment without significant improvement. She cultured staph, and culture-directed antibiotics were ineffective. Her pathology from her surgery demonstrated chronically inflamed sinonasal mucosa. So here's what she looked like in clinic. Again, so here's our middle turbinate. You can see polyps here within the ethmoid cavity. You can see this kind of white creamy material. This is what we had cultured and grew staph. She'd been treated with oral steroid taper combined with culture-directed antibiotics and still looked the same and felt the same. Let's look back at her operative pathology. So this is a very different picture from the patient who we saw before. Here's her epithelium, and this is her polyp. And really, we don't see the eosinophils that we saw before. What we see is primarily a neutrophilic inflammation. These are all neutrophils here. There's certainly lymphocytes throughout as well, but really a significant influx of neutrophils in this polyp and a predominant neutrophilic inflammation. So this is a different disease process. This patient had a normal eosinophil count and total IgE, so her blood work was different as well. So this is a patient who we ended up treating with macrolides, and this has been described as a treatment for polyps, as I mentioned at the beginning of this talk. For me personally, I used to use this, try this a couple of times in patients who had primarily eosinophilic disease after I'd exhausted other treatments, and just felt, wow, this doesn't seem to work at all. And this is a longer-term macrolide treatment, a little bit lower dose, but it has been described, and a lot of the papers that have been described as being effective come out of Asia, and so there's a higher incidence in these Asian patients of neutrophilic polyps, this sort of non-eosinophilic polyp disease, which appears to be a different type of disease. So here's our patients after treatment with macrolides. This is her nasal septum here. I'm sorry, this is before. So we'll do a little pre and post. So you can see all the inflammation, the thick mucus, the polyps, et cetera here. And so here's, she went on 3 months of macrolide treatment. And this is her, we use clarithromycin for her, and this is her afterwards. You can see really that marked improvement in inflammation. Her symptoms improved as well, as would be expected based on this endoscopy. So this was sort of this is a relatively small percentage of patients who I see, but I think it really highlights the importance of using methods other than simply defining patients as polyps or non-polyps in determining what's the appropriate treatment for them. So I'm going to stop here with these conclusions. I think the sinus polyposis, it remains a difficult disorder to treat. Endoscopic sinus surgery, I think, is a very valuable treatment in a component of treatment for these patients, and medical management, both pre and particularly post-operatively, is really critical in maintaining good results for these patients. So thank you for your time and attention. I will stop my screen share here, and I'm happy to answer any questions that may arise.
Thank you very, very much. Very nice talk. I think everybody enjoyed it. We do have a few questions. I don't know if you could, can you look at the chat? So thank you, guys. I was hoping that Dr. Pletcher would join us, but I was trying to locate him on and I don't think he was able to join. He said that he was quite busy. But what I would like you to do is that, I mean, this is another reason to really get the app, is that if you have the app, you could send all those questions and I could relate those to Dr. Pletcher. So again, thank you very much. Thank you very much for joining us, and I hope to see you tomorrow. Thank you.